latest technology, we know that after some age we all go back to our children to understand how to open a lock, how to work out password, how to use the technology, how to use the mobile, how to use the latest app. So if there is somebody in your house that we teach in your home, it will make our job very easy. And with this, Dr. Manoj, Dr. Mohan, it is 4:30 in the evening, and I welcome you both as the faculty and all the DTOs from all across the country and the faculty from all across the globe. Today is going to be very, very interesting session that we will have. And we will have discussions on how we can use data to do decision making, to take actions, to affect on policy. And the way Dr. Manoj and Dr. Mohan have stitched the entire presentation, it will be very entertaining, very, very interesting, because the views and the inputs will come from our fellow colleagues and DTOs. Today is also a wonderful day. We will have two of the DTOs amongst us to present their PDSA so far. I know that as of now, we have just made the aim statement, we have made the teams, we have made the process maps, we have just made the process measures, and now we are planning what do we intend to do. So we will have two DTOs present their PDSAs also. And henceforth, now every week we will have some or the other PDSA presentation from amongst you all, so that it is very encouraging for all of us. So I will not waste much of time, and I invite Dr. Manoj and Dr. Mohan to please start the session for today. Welcome, please.
Great. Thank you so much, Commodore Raman. Welcome. Namaskar. आज अपन डेटा के बारे में बातें करेंगे. Dr. Mohan, welcome to you also. Delighted to have you join in, and we will be talking about data to action. Really, data can do a lot of things, but we want to be able to see how it can change our lives, right? That is what we really want, and change it for the good. And so, yes.
Yeah, Manoj, it's also said, why collect the data if you're not going to use it, right?
Yeah,
if you don't collect, if you don't use the data, it's time wasted, worthless.
Absolutely, absolutely. So before we get into the data discussion, one of the things we have done before, पहले अपन ने जो करा है कि अपन कोई नई बात जो रिसर्च में या कहीं पे जो नई बात आई है उसके ऊपर बातें करते हैं. तो if I'll take the screen control, and I can begin to share the slides. And what we want to talk, something new that has come in the literature is this concept of subclinical TB. Yeah, I got a present data study yesterday, and it talked about this whole idea. And I want to take 2 minutes and introduce this new concept that I also learned and didn't realize the importance of this study. It just got published in MedX yesterday. It is going to go into a major journal. It talked about this idea that subclinical TB causes significant transmission. मैंने पूछा कि what is this detailed about subclinical TB? We know clinical TB when they have symptoms. We know latent TB that they don't have symptoms. Subclinical TB is when there are no symptoms, asymptomatic, and yet their sputum is positive. Think now like COVID. COVID asymptomatically transmit hota hai, इसीलिए it was causing so much problem. Same thing, that is what subclinical TB is doing. What this study showed was the following, that 68% of the global TB transmission, imagine this, is occurring through subclinical TB, through asymptomatic transmission. This is their line, suggesting an estimated 68% of global transmission is from subclinical TB. No symptoms, and the sputum is positive. Generally, अपन ये find करते हैं, this is happening at household level. The study was done in multiple 12 to 14 African Asian countries, and they were looking at household transmission. I share that with you. And now, Dr. Mohan, we shall go into data and to action and interpretation. So I would ask even our DTOs who are here, Dr.
Manoj, I
Mohan and
think
others.
everybody has seen such kind of presentation once or the other. I would like to actually bring in some comments.
Yes, please.
From our details, what is their thinking, whether it is half full or half empty, right?
Absolutely.
Can I have anybody, please? We can give it in the chat also.
And I'll let Commodore Raman and others to look at the chat and add those comments in.
But Manoj, it's all about your thinking, right?
Yeah.
It's about how you perceive the things.
Right.
So, and in my opinion, it's basically depends upon where you stand, which side. So can you just tell what they mean, what it means?
Absolutely. What I want to show is the data is the same. So what I'm saying is there are already 4 ounces of water in 8 ounces. The data doesn't change, but it depends half empty and half full. If you want more, you can say, wait a second, it's half empty, I want more, right? That's how one interprets. So what I'm saying is that data is one thing, interpretation is another. So we are going to have to learn the difference, which we already know, but then to use the interpretation for the point we're trying to make. Manoj, yes, Dr. Mohan.
To me, it seems like you're saying, if I go in front of a secretary or the DM to present my data, and I say, okay, I am at 80%. So there can be 2 kinds of reactions. Oh, you're only at 80%. Or the other could be, wow, you have reached 80%, right? The data isn't changing. But how the other person, where he is coming from, that perception makes a lot of difference, right? In the attitude makes a difference.
Yes. Now, and we will be also talking about strategies, right? If everyone is at 30, 40, 50% and you're at 80%, comparison can make a difference, right? Also, we can see what is remaining and how it can be reached. That can also make people a difference to better understand. So what we're saying is you need to be able to take that data and interpret it to the direction that you are thinking.
So can we, at this point of time, get one of our DTOs to come in and share their thoughts about how they would look at the data? And I would call upon, please, Manoj.
Yeah, absolutely. Before we go to that, I would make the comment that we have to take that data to action. There are some steps in between. You observe the data, you do synthesis, you do analysis, and then you do interpretation. Aaj pure din, for the next hour, what we will be doing is going to be having that conversation of how do we go through this process. So with that, absolutely, let us have our first guest.
I would call upon Dr. Zafrullah from Dhanbad, Jharkhand, who is in charge of the state district TB office, and he has already established the Culture DST lab individually through his push in the medical college, and also is currently setting up the line probe assay in the district. So upping up the Culture DST facilities in the district, and he brings a lot of experience from COVID, non-communicable disease, Ayushman Bharat, which is a flagship program of the government, and managing various CHCs across Bihar and Jharkhand. So I would like to, welcome Dr. Zafrullah to this. And, sir, I would like you to, just tell me, we have been looking at these slides for almost all the district, and everybody looks at it differently, right? So, sir, when you sit down on your data and you look at this slide, there are ups and downs. We have seen over COVID what has happened, but how do you look at this data? And when you have to work on the data, action, sir, ab kya karte hain? What is the specific things you look into? Can you just throw some light on it, sir?
Yes, sir. Thank you, sir, for inviting me on such a bigger occasion. Looking at the data, this is of 2021. There are lots of ups and downs, and the final was 85%, which I was not satisfied.
Okay.
because I wanted around 94 or 95.
So,
But after that, I started dissecting all the data
so
by
what you
TU
mean, sir?
wise.
Dissecting means breaking down the
Dissecting
data.
means breaking down the data
Okay.
TU wise.
Okay.
Then
This is
I
what you
came
mean.
to,
Okay.
yeah. So you can see at the bottom, there are four TUs which have let me down, namely Balyapur, BCC, Kendwadi, and Govindpur.
Okay.
So I concentrated on that, and I found one was that is universal for Dhanbad. There is a shortage of HR.
Okay.
Then I thought, then I came to find that I needed to sensitize the MOs on duty because the referrals were very less. Then upgradation of the lab, whatever deficient they were in, and then the sensitization of the SAIAs. That was very important because they are the root level field workers, and they should be sensitized so that and encouraged to give the sputum
But
collection
sir,
and transport it to the
sir, what I
DMC.
understand, जो मैं सीख सुन रहा हूँ, what I'm understanding is your majority of notification was from three districts, three
Yeah,
TUs,
three
three TUs,
TUs.
and overall we were happy with the data of about 85-90%. But when you break it down, you see there's a lot of scope for improvement. Almost they are touching the bottom, almost
Yes,
very negligible notification. And
and
sir, one more thing, please let me know, were the problems same across the five TUs or different problems in different TUs?
uh, the SAIA was universal in all
Okay.
these TUs because they did not, and also the referrals were very less. And about the HR, that was different in different TUs, but the we can come over we can jump over this, and
Okay.
we can make it good. But we need to sensitize the SAIAs first, and then I'm doing a CME program on the 25th in my medical college for all the MOs and interns and JRs, so that we can sensitize the doctors because they should be a part of the program and take it seriously because we don't have enough time for the elimination.
Absolutely.
So,
2025
uh,
is the timeline we
yeah,
have.
according to the NSP National Strategic Plan, they have a role, a very vital role in boosting up the
Absolutely.
TV notification also.
Absolutely. But sir, just to summarize this, what I understand, even if our overall data looks good, when we break it down, we will find
Yes,
some of them, some areas doing very well, other areas not doing so well, right?
yes,
And
yes, sir.
that is the usefulness of breaking down the data. Sir, you are at a district level and you broke it down to TU level. If there is a medical officer sitting at the TU level, what can he do?
Sir, he can take active part. Like he should first of all be sensitized and he should know the concept of the TB elimination program.
G.
And when
And
he
break
has
it
this
down
in mind,
further.
like how
Can
many
you
cases
break it,
I'm,
sir? Is the
sir,
data available even below the TU level?
data, no, sir, it's not available below. It's available with the
With the
TB,
TU.
STS and STLS.
Okay.
That is available because they have the Nixel portal at hand. So if the medical officer in charge is not interested in reviewing the TB program in their meetings, monthly meetings, this
Yes.
is the problem. They are not reviewing the TB program.
So,
And
sir,
if they
I
review, they will know where to take action and boost up the program.
great. So, what you mean to say is at the TU level also, they should look at their data and
Yeah,
probably break it DMC wise or a subset or a PHC and all
PHI,
those, area
wise.
wise,
Yes, sir.
PHI wise. Great.
Yes, sir.
So, Manoj,
Yes.
this is about breaking a bigger data into smaller manageable areas, right? Thank you so much, sir, for
Dr.
giving your
So
thoughts.
absolutely. I'll add a couple of things, Dr. Zafarullah.
Yes.
I think this is amazing. आपने पहला step बता दिया है जो critical है. It is critical to look at the data. The first step is, wait a second. If you looked at all India data, Dr. Zafarullah, आपको ये थोड़ी मालूम होगा कि आपके district में क्या हो रहा है. Correct?
Right.
If you even looked at state data, you would not know. You looked
Yes.
at district data क्योंकि आपका in charge आपका whole district पर है. But then you said, let us go down geographically to the regions where there are TU levels of control.
Yes, sir.
Now imagine empowering these MOs who are in these regions and you show them You go to Baliapur and you show them, look, all of the other ones are doing this, and Baliapur is low. Why should it be low? Let them figure that out, also with your help. But that is the power of the data. Instead of saying you're not performing well, just show them the data, and then aapne bahut acha bataya. You took that data and then you took it to action. Do you see how powerful that is? That you said, I'm going to do a CME. I'm going to do this activity targeted in this region.
Yes.
Because the data drove you to action. Now imagine if every DTO in the country did exactly what you are doing. Imagine that, how powerful that would be.
Yes.
Commodore Raman, you have some comments, please.
Right.
Yes,
Use of
I will
resources,
just take
yes.
1 minute, and DTOs, I just want to draw your attention to the entire PDSA and the curriculum that we are sharing with you. Here is a case in point that Dr. Zafarullah saw his data, and it occurred to him that otherwise the district was supposed to be doing well. But why is the data not moving the way he wanted? He wanted 92, it was not moving. Why? The root cause analysis started automatically by seeing the data. The first why took him to Govindpura. The second why took him to that, the lab needs to be upgraded. The sensitization needs to be done. Then it led to him automatically. So what should I do? Oh, 25th, there is a CME coming. That gives me an aim. That gives me an objective that I will do this intervention. And absolutely 90%, 95% of the human beings, which are our staff, are well-meaning people. They want to do good. Once you discuss the data with them, as Dr. Manoj said, you will have to not speak further. They will also get triggered to make sure that the data reaches to the lines. Over to you, Dr. Manoj, Dr. Mohan.
So I'll say this, Dr. Zafarullah, if you
Yes.
took the data and showed it to the MO at say Baliapur, he or she himself will begin. The first thing they will look at is their line. They will look at where they are in that
Where
line.
I stand, where I stand.
Yes.
It's a healthy
please.
competition now.
Yes, it's healthy. So Commodore Raman, and I would ask others.
I think there is
please
somebody
put
has
your-
raised a hand.
Dr. Kaushik Das has raised his hand.
Please, sir.
Please, go ahead, Dr. Kaushik. Or you may put your questions or comments in the chat for for Commodore Raman as well. Dr. Kaushik, we're not able to hear you.
Unmute KJ.
Okay.
He's there.
Yes.
Yes,
Please go ahead.
Unmute, sir. You are muted. Okay. Aapki awaaz.
Hello, sir. The DTO Dhanbad, sir. How you manage the HR issues?
HRD, actually, I'll tell you what. There was a big problem regarding the HRD because we needed around 9 to 10 STS and we have only 3. Now, what has happened recently that we got a message that all the MPWs and all the CHOs, they will be CHOs at the SWC level. They will be formed as PHIs.
Wow.
And we have trained the CHOs also to look after the patients in their area, get a contact tracing done by the Sahiya, and we have given them cups for collection of sputum, and we are also will be giving the drugs to be disseminated from their end to the patients in their area.
Great.
So I thought that this was a big hand, even if I don't have the TB program personnel. CHOs are quite a good number, and MPWs are also joining in. So we have a large force.
So it's
So
maximizing the available manpower, sir. Great.
So that was you do not shrink your hopes. That's you don't have a HR problem. We have these people, and if you get to train them, you have a very far off hand to handle things there.
So, sir, one more learning over here is use the available resources efficiently.
Yes,
Right.
sir. Yes,
Unless you get more resources, use it efficiently. Great. So,
Yes.
Manoj, thank you so much, Dr. Zafarullah. But
Welcome,
Manoj,
sir.
there is another way we can look at it, right?
Yes.
And I
So
would like to call, Dr. Srivastava, who is the district TB officer from Badohi district in UP, and he has also worked in Maharajganj previously as a DTO. He has, as many other DTOs, additional charge of blood bank, HIV/AIDS, and he actually has been appreciated by the Chief Minister for outstanding work in the district. And he has undergone training recently from the NTI Bangalore. And sir, I would like to welcome you first of all to this session. Thank you so much. And sir, we just heard from Dr. Zafrullah. He broke down the data, notification data, into smaller parts like TU-wise and try to find out where he should work. But is there another way you look at this data, sir? We have this data from January 19 to May 22, and we can see dips and rises, dips and rises. But you would want to know how to work and where to look at, sir. Can you throw some light on that, sir?
Definitely, it will be helpful if I see the data TU-wise.
Okay.
Apart from this variation,
Yes.
because year 2020 and 2021 was COVID-affected years. So
Yes.
due to COVID pandemic fluctuations and other
Where the-
seasonal variations, is graph is going up and down. So it's not very, I mean to say, helpful, because this variation is because of COVID pandemic fluctuation. At many months, OPD was closed, hospitals were closed. People were afraid of testing COVID. They don't go to OPDs for checkups. So that was the reason why this
You mean
graph is fluctuating.
external factors, sir. External factors were also there, and
Well,
in
we are
addition to
playing,
that,
external factors were playing. Yeah.
okay, Manoj, can we go to the next slide, sir? Okay, sir, you have shared this slide also with us, sir. So what else would you like to look at in this slide, sir? What are the key points, sir? Hello, sir, are you?
yeah, yeah, we can hear him. So Dr. Srivastava, you did a sort of a
Sir,
root cause.
ये आपने रूट कॉज एनालिसिस हमने किया था सर डिस्ट्रिक्ट में, तो सर आपने 3 एरिया बताए सर. वी हैड डिस्कशन व्हेन वी वर्किंग ऑन योर पीटीएस. यू सेड एक तो पेशेंट को लाना बहुत जरूरी है उस पे हॉस्पिटल में, और दूसरा डॉक्टर की सेंसिटाइजेशन वरना वो
Patients to PHI, and the next thing is the identification by medical officer
Yes, sir.
of presumptive TB cases. And next is lab testing, proper lab testing.
So you mean सर कि अगर ये तीनों हम TU वाइज भी चले गए, कुछ भी ब्रेक कर लिया, बट अगर हमने वेरिएबल्स को नहीं देखा, what goes into the notification, that is also important. इनका डेटा देखना.
Exactly.
Right. So again, Manoj, the same data, same trend
Right.
line, broken differently. Right, sir? So, sir, are you working on these ideas separately, with identifying where you have which problem?
Since I joined as a DTO in Bhadohi on 1st of June 2022, I worked as DTO in Maharajganj, and the appreciation certificate I got from Chief Minister in Maharajganj, not in Bhadohi.
Oh, so you are just looking at this data and
2021.
breaking it down. Oh, I understand.
Yeah.
You are actually now
Yeah.
breaking it down, this data, for your PDSA.
Yeah. Exactly.
Okay, along with, so Manoj, again, a proper use of a process mapping along with a trend line.
Perfect. So let me just add a couple of areas of insight into this. First, we heard that we can take the data and break it out geographically.
Yes.
And that helps us determine where the issue is, and asking the whys, as Commodore Raman said, you ask the whys. The second, what Dr. Srivastava is saying is, but wait a second, you can break it down geographically, but know also the data of what is happening in the processes. Is there a problem in getting the patient to the PHI? So he looks at the PHI data, right? At the Peripheral Health Institute. Yes, you can do it at a regional level as well, or you could do it at a district, but then you can also do this at the TU level, which will help you figure out why there's a problem. Or is there a problem with referral? Or is there a problem with testing? So then he looks at individual data at those 3 critical points in decision-making and change.
So Manoj,
So
here we have
really exciting.
somebody breaking it down TU wise, and another district adding up saying, good, you break it TU wise, but even in that, look at the input which are going wrong and correct those probably in your focused areas.
Absolutely. Absolutely. So now we've learned that these are critical ways of looking at data, your own data, and being able to make action and decisions. So
But Manoj, on
yes.
the other hand, it also shows that by itself, a trend line doesn't show us much unless we break it down into
Yes.
certain different parameters or different forms.
Yes. And a trend line has no purpose if it gets shelved in or put in a report and not taken action on it. So I see Dr. Ajay Kumar has a comment or a question. Happy to, if you please go ahead, unmute Dr. Ajay Kumar, and then we can hear your comment or question.
Hello, good evening, sir.
Good evening.
सर मेरे को ये पूछना था कि जैसे इन्होंने ये किया हो कि पेशेंट जो है वो डायग्नोस्टिक उसके नेगेटिव आ गया, तो ये कहते हैं कि सिम्टोमेटिक ट्रीटमेंट दी है, क्या ये पेशेंट को उसके बाद भी ट्रैक कर रहे हैं कि वहीं पे छोड़ रहे हैं?
सर ट्रैक कर रहे हैं सर, ये जो बात हुई थी पीडीएसए में, they are tracking the case even after that. It's an individual thing at different level which is being done, sir.
कितने टाइम के लिए ट्रैक कर रहे हैं इन पेशेंट्स को?
सर वो इंडिविजुअल वो रहता है सर हर एक का, ये अभी we haven't gone into and closed the whole system, but it's like sir said, we are still working out the data, and he joined only about 10 days ago. That is still working out these finer points for this PDSA. Started doing this with the PDSA, and we are presenting this here.
Yeah, and
okay,
we would be, yeah, and if other DTOs can share their ideas on how long they're tracking, please put it in comment, and Dr. Ajay Kumar can have a better insight on what others are doing. Right, here's a great opportunity. There may not be a direct guideline that you track for 3 months, 6 months, 12 months. These are subtle things that we learn when we engage with one another, and when we begin to do a drill down.
These are the things when they try it, test it, we never know, tomorrow it may become a guideline.
Absolutely.
That is how it becomes guideline.
Perfect. Okay, so now we have time for hearing our first PDSA. Commodore Raman, so we would love to welcome our first PDSA from Dr. Gupta.
Yes, Ankita, may I request you to start sharing your screen, and we welcome Dr. Gupta. Dr. Gupta has been at AIMS as well, and has also done training at Russia. He is the MOTC at Tikamgarh, and we are very happy. The objective is, when we were doing the PDSA with Dr. Gupta, we found him very, very active. Half of the time, DTOs, we are selfish. We learn from you. It is a fact that each time we have meetings with you, we end up learning from you. And may I request Dr. Gupta to present his PDSA and his thought, what he wishes to achieve. For other DTOs, there are two meanings in this, that, this is how you all will be making your PDSA presentations. See how easy and simple it is. Dr. Gupta, please go ahead.
Thank you so much, sir. Good evening, everyone. Since I joined this program in April 21, I stayed for just 1 year. बट मेरा यहाँ पे सबसे बड़ी लर्निंग थी कि टीबी इज नॉट अ सिंपल डिसीज जो बाकी बीमारियों जैसा है कि आपने पेशेंट किया. यू हैव टू ट्रैक द पेशेंट, you have to bring the patient to your DTC or DMC wherever you are doing microscopy and all. तो हमारा सबसे बड़ा इशू यही था पीडीएसए में कि अगर हमें नोटिफिकेशन पढ़ाना है.
सर आपका वॉइस कैन यू चेक योर वॉइस?
Yes, go ahead, Dr. Rahul. I think your voice is not coming as well.
Can you hear me now?
Now it's better. Now it's better. Please go ahead.
Okay. So हमारा
चप्पल देजी
Yes, go ahead, Dr. Rahul.
So हमारा notification जो था around, it was around 75%, and we were not happy with this कि हम just 75% ही अचीव कर पा रहे हैं. तो हमने अपना डेटा देखा. जो हमारा मेजर ड्रॉबैक था कि हमारे एमओ, हमारे आशा जो सीएचओस हैं, उनसे हमें उतना प्रॉपर हेल्प नहीं मिल पा रही थी. उनको सेंसिटाइज किया, उनको हमने टीबी प्रोग्राम में एक्टिवली पार्टिसिपेट करने के लिए इनकरेज किया. अगर हम उनके वजह से ही हमारे पास पेशेंट का रेफरल बढ़ रहे हैं और रेफरल की वजह से हमारे पास पेशेंट का नोटिफिकेशन भी हो रहा है और काउंट बढ़ रहा है. सर जैसे एक और दूसरा इशू जो हमारे यहाँ था, एचआर का इशू. तो जैसे हमारे प्रीवियस डीटीओज ने बताया कि हमने अपनी वर्कफोर्स को सिर्फ टीबी स्टाफ तक ही लिमिटेड करके नहीं रखा. हमने हमारे यहाँ भी एससीटी अपने एजेंट्स की कमी थी, हमारे एसटीएस कम थे, तो हमने एमपीडब्ल्यूज और दूसरे लोगों को चार्ज दिया और उनसे हमारे टीबी का प्रोग्राम काफी अच्छे से चल रहा है. सर
Sir, I would request you to go ahead with the aim statement and the process measures that we have discussed.
हाँ, जो हमारा अंकिता जी के साथ डिस्कशन हुआ था, डॉक्टर अंकिता से, तो हमारा मेजर ड्रॉबैक जो बाहर आया वो यही था कि हमारे एमओ सेंसिटाइज नहीं है, हमारे आशा उतने ज्यादा सपोर्ट नहीं कर पा रहे हैं, हमारे सीएचओस भी टीवी प्रोग्राम में एक्टिवली पार्टिसिपेट नहीं कर रहे हैं. तो उनके सेंसिटाइजेशन का हमने प्लान किया, उनके सीएमईज कराए. आगे भी हमारे प्लान है. अभी 25 को हम हमारे डिस्ट्रिक्ट के सारे सीएचओस की एक एनटीपी मॉड्यूलर ट्रेनिंग कर रहे हैं 2 डेज की.
सो डॉक्टर गुप्ता, आपने जो अपना एम स्टेटमेंट बनाया है, वेरी स्मार्ट एम स्टेटमेंट, आपने क्लियर कर दिया कि आई एम फोकसिंग ऑन निवाड़ी एंड टीकमगढ़ जो आपकी दोनों डिस्ट्रिक्ट हैं, और 5% आप विद इन 2 months का आपने उद्देश्य अपने लिए बनाया है. दैट इज अभी हम देखेंगे आपकी जर्नी. बिल्कुल ठीक है, सेंसिटाइजेशन ऑफ एमओज एंड आशास, वेरी गुड थॉट. नाउ व्हेन यू विल स्टार्ट डूइंग द पीडीएसए जर्नी and we will put every bit of data. Abhi to it has just started. The wonderful journey. You have just purchased the ticket and you have sat in the train and you have located your seat and you become comfortable. Now the journey will start and you will see how beautifully you will get to know where is the exact problem. You will start monitoring, start putting the data, and that is when the fun will begin. So thank you so much. Ankita, is there any point we have missed?
No, sir. No, sir. There is just graph which he had made for both the districts.
Show the graph, please.
Great.
There is a graph about TV notification. So, sir, can you see during pandemic in March, April, May, there was a very big dip in our notification, and after that there is a very high notification rate for last like 2 or 3 months. At that time, sir, we have taken very harsh and intensive measures. हमने सर फील्ड में जाके हमारे जो रिमोट एरियाज थे वहां जाके कैंप किए. Like in 1 month we did more than 15 camps. मेरा पूरा मंथ उस टाइम ट्रेवलिंग में निकला सर, और हमने काफी अच्छे से अपना नोटिफिकेशन टारगेट कंप्लीट किया, नोटिफिकेशन बढ़ाए, एंड those 2-3 months were very good, एंड हमने अपना नोटिफिकेशन के लिए जो भी कर सकते थे किया.
Great. So DTOs, for all of you to see, all of us have to just reach this level right now. Our aim statement, our PDSA team, our TB notification graph, and we should know what are the interventions we are planning to do. this is the level where we all have to come. And this is for all the counselors also, and this is for all the team leads also, to see that this is the level by 15th of June, which we had planned. Today is, of course, 17th, but this is where we should all be. If somebody is not yet reached that level, make sure, counselors, that we bring up ourselves, aim statement, process measures, planned intervention, and the graph. Okay, so we move ahead, Dr. Manoj. Thank you, Dr.
Perfect.
Rahul. Thank you so much.
Thank you, sir.
Dr. Rahul, thank you so much for sharing and then sharing your aim statement. You have made an aim. What you have done is you have taken action. Making an aim statement is that looking at the data, you said, look, I have to do something in these two districts. You even did that analysis of where you wanted to target. And then you looked at, and you are now taking action. So looked at the data and take action.
Yes.
Let's talk more about now looking at the data. So I want to share with you how some of the major corporations in the world look at their data and how they have become incredibly successful. मुझे आपको एक केस स्टडी शेयर करनी है. आपको आपने FedEx, Federal Express का नाम सुना होगा. Federal Express is a company, $90 billion. उनके CEO जो शुरू कर रहे थे, founder was Fred Smith. वो करीब मेरे से 1 ब्लॉक दूर, करीब 150 yards दूर रहते हैं. यहाँ पे उन्होंने जो कंपनी शुरू करी थी, उन्होंने पैकेजेस डिलीवर करने की कंपनी शुरू करी थी. और उन्होंने अपना पूरा, he based everything on quality. Can I deliver quality to my customers? And he used to look at his data, and he still today looks at his data in detail. But what type of data does he look at is really, really important. So early in the company, when he said, I want to know, he told his managers, what percentage of the packages are delivered on time? The manager was very happy. He was very happy. Monday ko 99.9%, 99%. Wednesday ko thoda slow tha, 99.8%, didn't get packages on time. Very good. Dr. Mohan, मैं आपसे ये पूछूंगा, how does this data look to you? Or Commodore Raman also. Yeah, please.
Manoj,
Yeah.
I would like to say data looks good on paper, but when you, blow it up to proportions, it will show where the problem lies. I'll give you one more example. A 0.0001% error, a 0.0001% error in the direction of a comet would mean it will directly hit the earth and not pass the earth. So understand the difference in values when you go to scale.
Right. So values to scale is important, and what numbers you're taking a look at.
If this was 1,000, I'll be happy. If it is 1 million, I will be not happy, because there'll be too many customers who are not happy.
So let's look at what he did. What he said was to his managers, I don't want to see this data. I don't want to know that what percentage was on-time delivery. Tell me, if I have 1 million, 10 million customers, what are the numbers of unhappy customers? And then this is what the data came. 1,000 on Monday, unhappy customers, 1,000 on Tuesday, 2,000 on Wednesday. All of a sudden, everything changed. So same data, but how we delineated and we presented and we looked at it. As a manager, as a DTO, this is your decision. You're the one who's going to make the call, whether you want to take this data or you want to take this data. Now, I will say this, for his customers, when Fred Smith advertises, he says he shows this data, right? He wants a new client, he shows this data, that 99.9% on-time delivery. But when he shows it to his employee, because he wants to improve He wants to sustain, and he wants to make sure that he is reducing the error rate. He shows this data. So you can see the same data being able to be used in different ways. This is where you, as a DTO, make the call.
It's up to the statisticians how they want to present the data, whether they want to make it look good or they want to make it look bad.
But good and bad is reflective of who is presenting and who you're presenting to.
Audience, who's the audience?
The audience. And what we're making a point of here to all of our DTOs is you need to be able to look at the right numbers. So for example, look at the numbers that will motivate your employees to do quality work. Look at the numbers of patients that have been defaulted and how you can reduce that to 0 fault, right? Why should any patient have a complication or become defaulted? We should work towards 0 fault. So that's the point of sharing this story and this case. Now we shall go to our next presentation and next conversation. Commodore Raman, shall we have our next presentation?
Yes, I take this opportunity to welcome Dr. Ishwar Raj. Bhumika, please start sharing the screen so that we don't waste a second. Dr. Ishwar Raj is the DTO of Adilabad, Telangana. He, through his performance, has achieved 5th rank in the district in Telangana state and 61st rank in the country in the TB program. And if you please have a look at the screen, DTOs, before I welcome Dr. Ishwar in, have a look at the screen. He is already working at 110% of the target notifications. And yet he finds the objective in the PDSA and wants to take it to beyond and reach 115%. That is the objective that he has planned for himself, and he has got his interventions planned. So Dr. Ishwar Raj, it was a pleasure to interact with you during the session. I welcome, and please share your aim statement and what do you have in your mind?
Sir, good evening all, sir. Thank you for giving me this opportunity, sir. I'm very happy to share my district data. Sir, here, actually, we have achieved more than 110%, sir. But we achieved more than 90% during the 2021, and during 2022 till up to June, we achieved 110%, sir. Simple, sir. My plan is every month. Sir, I'm audible, sir.
You are so wonderfully audible and clear.
Thank you, sir. Thank you, sir. Sir, here my PDSA presentation. Sir, actually,
go ahead, Dr. Raj. I think you've muted yourself, but unmute and continue because you're very much audible. We can see you.
Yeah. Go ahead, please. Go ahead.
Sir. In TB, sir, throughout India, not only in India, everywhere, sir, some myths, some lack of awareness is there, sir. So actually, क्या होता है, sir, बोल तो अपन अपना staff से और अपना क्या कौन सा अपना weak points है, उसको अपन every month review करके अपन उसको overcome कर सकते, sir. In हमारा आदिलाबाद में क्या होता है, sir, which is a very tribal district in Adilabad, in entire Telangana. We have a target of 15-20 per year. We have a target of 127 cases per month. So here what happens is, sir, we have excellent HR and we have excellent structure. Patients are referred by ASHAs and patients are referred by private practitioners. And we have a RIMS Medical College. Therefrom also we have referred patients. And patients are aware, sir. About 80 to 90% patients are self-aware to visit DMC because we are giving excellent services to them, sir. So by that, they are self-aware to come to our DTC, that is in district, which is nearer by our RIMS Medical College. And in 80 to 90% are coming, but 20% are lag behind. So that we are planning to conduct ACF every month, mainly on Tuesdays or and Fridays or Thursdays, because On Wednesday and Saturday, there will be a session, and on Mondays, there will be ANCs in PHCs, no, sir. So we are planning to conduct ACFs on Tuesdays and Wednesdays, Thursdays and Fridays. So that's the reason we are achieving more than 100%. Patient will never, बोलता उनको services कहाँ भी मिलता है सर. Every month I am my TU wise review करता हूँ सर. कौन सा PHs पूर है वो TU STS को STLS को responsible लेके उनको आशास को समझा के every month 10 samples पर आशा लेके आने का ऐसा samples ऐसा ACFs conduct करते सर. हम हमारा अभी processing map sir. We are planning to increase our notification to up to 115%, sir. Already it is 110%, and we are planning to improve 115% by 2 months with the help of NTV staff. That is our key staff, STS, STLS, and we are planning to use some PHC nodal persons which are working for exclusively for TB, leprosy, and some NVBDCB programs, sir. We are very much good understanding with them, sir. Sir, next our run chart is during the month of January, sir, from January to May. In January, sir, we have conducted ACF through ACF vehicle, sir, which is स्टेट से हमारे को एक व्हीकल आया था सर, उनको completely यूटिलाइज कर लिया सर. उसमें एक्सरे मशीन विद CBNAT फैसिलिटीज थे सर. इसलिए 150 केसेस को हम केसेस को स्क्रीनिंग किए थे सर. 40 out of them 49 were found positive, sir. During the month of Feb, we conducted screening to 106 patients, 106 members. We have found 9 positives, sir. During the month of March, we screened 145 patients during ACF camps. We found 21 positives, sir. During the month of April, we screened 108 patients. We have symptomatic patients. We have found positive 5, sir. Sir, our target is 127, as I mentioned earlier, sir. So in January, we achieved 149, sir. It is more than above our target. And in February, 156. And in March, even in summer, we achieved 122, sir. Even in April, 138. Even in May, 131, sir. Every month, we are achieving more than our target, sir.
So
Excellent.
we will be way now. Yes, Dr. Manoj, you were saying something?
So I can add to this. So Dr. Raj, and there was a question also by Dr. Sudha on the achieving more than the target. So we'll be discussing a little bit more. The target is what was determined by WHO and CTD based on the demographics of your region, of your district. Now, the target is a goal that you want to reach, because once you have reached that target and you sustained at that target, what happens is then you begin to see a decline, because there's no more transmission that is going to be happening if you achieve that target. Now, targets are not perfect. Granted that they might be sometimes too high, sometimes they may be a bit low. That is not perfect, but it is a scientifically derived methodology that will help us have a standardized approach to thinking. And what we know, the goal, the target is something we want to be able to achieve, because once we are at that plateau, then we begin to see that 5 to 10% decline per year. What you have seen in other slides, and I'll show in future slides, we'll see, is that we have been at that same notification number and incidence number for a long time. It is because oftentimes we're not able to achieve that target. But please, yes, please.
Dr. Mohan, I'll just finish it in one, then bring you in. So, Dr. Ishwaraj, thank you so much. And I had to, you have gone way and beyond because you have grasped the PDSA and you have, backtracked and put your data. And your learning of the PDSA technique is definitely higher than everybody else right now. We will be monitoring your PDSA. Please keep on this journey, and I'm sure you will get much more better results than you obtained so far. And I'll be particularly interested in district as we discussed in the session also. And Dr. Manoj, the point that you brought out and Dr. Sudha rightly pointed out, how can it be 110%? Now I'm addressing all the counselors and the team leads and the DTOs. That is the reason we are not working on a target in the baseline. That is the reason Dr. Manoj today will be talking only of graphs. He will be going further, and Dr. Mohan will also be talking only of graphs and trying to showcase how this notification has to go up. And they will not stop at boosting. Today, they have got some other plan. They will go beyond boosting today because we all know that there is a scope for that. Dr. Mohan, please. I was itching. I couldn't help.
I would just say one more thing. These are basically guiding markers, right? It doesn't mean that you have to stop there, or if you don't reach there, you have done something drastically wrong. They can be too, like Manoj said, they could be too high for you. They could be too low for you. You are the best judge in your area because you know in your area where the patients are missing, where we are still not able to reach. You have to use that as guiding lines, but think of going beyond it if it allows you, if the overall context allows you to do that. And we'll be discussing that also as we move forward, Manoj.
Absolutely. So with your WHO consultant, all of you have a WHO consultant. They are well versed on the target. They're well versed on the notification. You look and you have a conversation. What will it take to achieve that target? Is our target appropriate? And we'll have more conversations on that as well. So with that, PDSA, we heard from Dr. Raj how he made an aim statement. He's doing these interventions. All of you should be at that stage in having the aim statement, your process measures, outcome measures, your team developed, and soon you'll be getting your data as well. Now, let us go back and go even deeper in our conversation about data, how that data impacts us, how it changes us. So let's share another conversation, another set of data from Dr. Manoj Dave.
Yeah, I would like to call on Dr. Manoj Dave, who is the DTO in the biggest district of India, as I mentioned earlier, Kutch. And we were discussing that he has done very innovative things in the COVID time. And when we look at the data, also we see a lot of things changing. So, sir, can we move forward? Next slide, so that sir had shared. This is the data when we have private data, but there's another interesting slide. If you go to the next slide, Manoj, great. So, this is the data for the last 8-10 years. He's looked at it in a different way. But Dr. Manoj, Dr. Dave, I'm sorry, Dr. Dave, I would like to ask you a question. When you look at your data, we see things going up, things going down. We have heard from two DTOs and the PDSAs, how they look at their notification data. Sometimes, we feel, am I alone or am I a part of a bigger group? Is there a problem only alone in my district? Or can I take help from somebody else? So, how does this work? Can you just, throw some light on how you look at this data, and then what do you do with it?
Good evening, everybody. From the previous discussion, it is clear that data is an individual fact, while information is the organization way to present and interpret the facts. By this, we can transform data into some information that makes some sense and tell us the facts. On that basis, we can analyze and do some decision to correct the situation for a requirement. We should compare data with the neighboring district.
Okay.
Or sometimes
like you shared with us. Manoj, can we go to the next slide? I think you did this, sir, with the neighboring 3 districts, right?
Yes, Morbi, Banaskantha, and Jamnagar. So I find that I am not alone.
Okay.
During 2020 and sometimes peaks and sometimes down trend, it is universal due to era of the COVID and some vaccination campaign was going on. So at that time, what I have done, for the benefit of the all the Gujarat, not only for my district, that I have started spreading one message daily for 1 to 2 minutes in WhatsApp group.
Okay.
That I had given heading that message Mala no manko in Gujarati. Mala jo mala घुमाते हैं 108 मणका की. So we have done sensitization of all by some simple message that ASA can understand, from DTO to ASA. And the focus was COVID, but I have faced bring TB also in the focus along with the COVID. So during the time of sample taking of COVID or during the vaccination, everybody was started screening every patient regarding the signs and symptoms of the TB. And along with the sputum, along with the samples of the COVID, throat swabs and nasal swabs, we were taking sputum collection also. So
Okay.
that we have started increasing during the 21. And now we are sustaining up to the May 2022. But still we are not happy.
Great. Dr.
Will be-
Dave,
Yes.
what this shows me is that you actually, what you have done in your district, and since you see other districts are also suffering from the same, nearby districts, and the
Yes.
geography is the same, population is almost similar, the demographics is similar. So what you have done there can actually be used by the neighboring districts also, and cross learning can take place, collaboration can take place, and we can actually pick up what has been done and use it. It's a very good thing to do and saves a lot of time for everybody also.
Yes.
So yeah,
Because
Manoj.
sensitization was not possible physically during that time.
Yes, so
Time
digitally.
was also a constraint. And Kutch is a very large district, scattered district. So journey time, everything is considered. And by this way, I was able to sensitize all the staff, health staffs. Even that message was spread in public also.
So what you have told us here is, when you are in a situation, you have another way of looking at data by comparing the data with others, right?
Yes, yes.
And then probably you can also talk to them and ask if they have done something to counter this thing. Like you told, you have done something and you are sharing for nearby districts and in Gujarat. So it's a good, exercise and learning with another area being opened about comparing data and see whether you are alone in this situation or as a part of a bigger problem. So Manoj,
Conversation
Perfect.
between all the DTOs in WhatsApp.
yes,
group.
collaboration, yes, and
What
learning.
I am doing or what they are doing. So best way we are picking up from them and they are picking up from me.
This
So
is
we can-
exactly, Manoj, I would like to point out one thing. This is exactly what was done in the COVID vaccine trials, cross learnings globally. And that is why we came up with, in a global sense, came up so soon with the vaccine, because people shared their information, shared their data, pooled the data and collaborated with each other. Right, Manoj?
Perfect. Yes, very much so. So, Dr. Dave, I'll add to what you said, but I'll also share a story. Yesterday, I was at a wedding, and it was people who I know very well, very closely, and they're from Kutch, and my best friend also is Dr. Dave here in US, and I share that story because I had a chance to have a conversation with them about what I was doing in TB, and they asked me how they could help. They want to connect with you, the DTO in that region, and to say these are NRIs. These are people who have been in the US for 20, 30 years or more. And they were so excited to hear that you all, the DTOs, are doing so much work in their home city, hometown. So I will most certainly work and connect to you to them. And I think you will enjoy talking to them and sharing the great work.
Sure.
Now, so wonderful. Now, the point that you made are two critical things. अपन जब compare करते हैं, it begins to make us realize that are we in left field, or jo humko experience ho raha hai, my experience is the same experience that others are going through. And when you did that, Dr. Dave, you found, wait a second, everyone is experiencing a decrease in notification. Even before the articles were published, even before NTEP put out data to say that we're seeing a 20-30% dip with the pandemic, you yourself knew that this was happening because you looked at your data, you compared it with others, and you verified that this is there. This is why it's really important to be able to look and compare apples to apples, right? You want to be comparing apples to apples. What's really interesting is you took it to action. You had your TBHVs, ANMs, ASHA workers, you began to sensitize them on the issues, WhatsApp messages, other things that you began to do. And you shared that with others to do that more. This is what we need every DTO in the country to be doing in order to achieve elimination. If we wish to achieve elimination, these best practices to do that. What PDSA does is standardizes this whole process. It brings the right data and the right apples comparison to apples. And it allows us to do that action, that intervention in a timely manner and see the impact of that intervention. So many things that you're doing, we can see the process by which they are. I see that's a hand raised. Dr. Namakal, would you like to comment or add? Or you can go ahead, you can add, comment or add, please.
He is connecting to audio. We may go ahead. And I am also making a list of all the DTOs who have raised hands. We will definitely be calling you towards the end. I have made a note of Dr. Kaushik Das also. He raised the hand again in between. I am making a note of Dr. DTO Namakal also.
Okay. Dr. Namakal, can you, I think you're still connecting
While
through
Dr.
audio.
Namakal is coming on, Manoj,
Yes,
you
please.
talked about collaboration and cross-learning. This, this BTN, we are having more than 300 to, we are having more than 500 or around 400 to 500 PDSAs which will be done, right? Look at the wealth of information. There will be slight differences state-wise, area-wise, geographical, but the process remains the same. We will have cross-learnings, and what you do today could go a long way in actually having that learning with the central TB division, getting it together. And what you do can help somebody in Assam, or that's how data sharing and collaboration works.
Absolutely, absolutely.
So Manoj, I think we can move forward until somebody is connecting.
Sure. So now let us talk another case study, and let us go and begin our conversation of boosting and going beyond.
Dr. Manoj, I'm sorry to butt in like this, but then I said,
please.
I will always bat on behalf of the DTOs. This is cheating in the game. You started with saying that we will do boosting of TB notification. Now this is maximizing. This is you have changed the goalpost. This is the rules of the game are being changed.
The rules are being changed because we are visionary people. Okay. We are people who are looking at not just where we're going, and we're looking beyond.
And that is done in sports. All athletes do this.
Okay. So probably this is what Dr. Sudha was trying to make a point. Why I highlighted it here is so that, once you amplify it more, Dr. Sudha will get her answers.
Yes.
Yes. So we have many people who have said, look, and we just, as you will see next week, we have over 400, 500 sets of data. We have PDSAs from each one of your districts. You have the ones who populated. And what we see here is that baseline was there, pandemic caused it, but then they got recovered. And now the question is, We are reaching boosting. What do we do next? And the answer is, then we must go for maximizing. So what do I mean by maximizing? What are we talking about here? The whole idea is that there are targets that have been developed. We've discussed this just a little bit earlier, that WHO, CTD, looking at standardized methodologies, have said this should be our estimated target. And what we need to do is to achieve that target. So the question is, why do we make a target? Because the target helps us see where we need to achieve before we begin to then see a decline of 5 to 10%. Sustained at that target, then we begin to see decrease in transmission. Aapko yaad hoga, the first slide I showed, that over 68% of transmission is happening asymptomatically in the global arena. Think about that. Now, once we get TB under control by increased notification, by rapidly diagnosing, by doing family checks of those who have been exposed, what we do is we cause this 5 to 10% decline every year, and then we need to improve on that. So boosting, and then boosting to maximizing towards the target. Now, there are two things. If you have achieved the target, right, then we should begin to see a decline. If you're not able to achieve the target, then we have to ask our questions. Why? Is there some issue with the methodology? क्या target ठीक है या नहीं है आपके लिए? क्या is the population mix, the input variables to calculate your target, are they appropriate or not? So for this, the WHO consultant can help you look at your targets. Then you can look अपने जैसे शुरू में बातें करी है, that maybe there's a problem with vacancy, maybe some CBNet or other, you are begin to able to do that. Not until you look at where you are, do that root cause, find out those variables which are modifiable or not easily modifiable. Until then you can say you're on the decline to reaching the target. So that is the idea, that you want to go boost and then be able to, after boosting, maximizing and going towards the target. Dr. Mohan, any thoughts and comments from your end? And then we will look at more data and more conversation.
Manoj, I would like to put, am I audible? Yeah.
Yes, please. Yeah.
I would like to put it in a different sense. You know, when we talk about objectives, we use the word SMART. And the SMART, the A is achievable, right? If I am at, and even in everything in life, to our children also, if they are at 70%, we don't ask them to reach 100% directly. We push them to go to 75. Then the moment they are nearing that, we push the target again, because then you can see the target. You are within striking distance. It keeps your morale high and boost. I'm not saying that is the reason here, but we need to understand that targets always move, and it will always move in life. So if we have to go to elimination, we have to ourselves have the benchmarking, and that's what quality improvement is. You benchmark every time and raise the bar higher, like a high jumper.
Exactly. So how did we go from the data to action?
It's basically
what we did was
these
we
4
had
5
to
things which are, yes,
correct. So just to give you a sense, we did observation, we did synthesis, we did analysis, we did interpretation, and then we took it to action.
Manoj,
right?
Can we emphasize on what synthesis is, so that it's very easily understandable?
Sure. Go ahead. What do you want to elaborate on that?
Yeah, basically what we do is we give a basic look to our data, and then compile, collate, and put it in different kind of easy to understand figures and graphs and charts. So that is data synthesis. It's not only numbers, they give you a story.
Right.
And
So
then you analyze that story.
exactly. You create a narrative from the data, right?
That is synthesis.
That is what synthesis is, that there's a lot of data and there. This may be at a political front. There are lots of events that happen and you compile them to create a story, a narrative that will be able to go for the further analysis, interpretation. That is what data allows us to do. So excellent. So Commodore Raman, I know we've done a lot. We've got, do you want to share some of this? And then we can talk more about this in future because we have other topics also to cover.
If we have other topics to cover, we can jump. Otherwise, if you want to take a pause, Dr. Manoj, I would request you to, we are talking of data. We are talking of observing the data, synthesizing it, analyzing it, interpretation, and then taking action. So we are dealing with data day in and day out of this DTO program. So why don't we show the DTOs the data that we collect from them, and how do we interpret it and how do we take action on that? So if you click the feedback of the DTOs, graph.
Yes.
Graph.
Yep. So before we that, I just share that. I'll go to the graph. Just to give you an idea, we have enrolled 534 data. Again, 139 are not been very engaged. You have been part of those who have been very engaged, and now we're looking at the feedback from your individuals as well. And let me see if you're able to see my screen here.
Go in the slideshow mode, please.
This is the best I think I'm able to do.
Okay, good.
At present, So are you able
maybe
to
go to
see
150%? It will help us.
Good idea. Yes, please.
Yes.
Okay. Are you able to see? Now?
Yes. Very nice. Very nice. It has come up well now.
Yes. So, Commodore Raman, how did our DTOs respond to these questions?
Okay. So let us be very clear, DTOs. We did the survey and the responses have been coming. Majority of the responses have come. Some are still pending. So my first request is, please give us our nutrition. हम आपका डाटा feedback खाते हैं. आपका feedback हमारा पालन पोषण करता है. So that's nutrition for us. So Dr. Manoj, we wanted to know how the program is being rated by the DTOs. So they have, on a count of 1 to 5, they have given us 4.2. Now, if you are the FedEx CEO, okay, I am very happy. If you're asking me 4.2, I'm very happy. But you would be looking at that 0.8 shortcoming.
Yes.
Okay? Yes. So why not 5? So where is, how much effort can we put in so that we can make our program acceptable to all the varieties of DTOs across the country? Because they all have different needs, and our program will be successful only if we are able to meet and address the needs of every kind of DTO from every geography in this country. That's my take. What is your view?
I agree. I agree that we need to be listening and looking at the feedback. And what we said, overall rating was between, so it was at 4.2. Then we asked them specifically, were the counselors helpful? And yes, they were helpful, again, at 4.2. What did they think of the tool? They liked the tool. So DTOs are like our organization and planning. And then the best question of all, that even you as a DTO would ask your patients, would you come back? Would you have your relative come? Would you recommend this course to other DTOs? And again, 4.3 thought, so this gives us, again, data that gives us a sense of where we are and what we are doing. And this is what we call quantitative feedback. There's also qualitative feedback, which gives us words in your own words, what you are saying and what you are thinking as well.
So definitely, Dr. Manoj, and at this point in time, counselors, you can see your report card is there in front of you and the team leads. Let's make sure that next time we share with them, it is at 4.5. Okay, you are the first point of contact.
If I may, Raman sir, you have made a perfect point over here. What you have given is you have given an achievable target within a timeline. It's 4.5, and everybody needs to understand this. Although we want to be at 5, but we should be aware of the practicalities and situation. And so benchmark is now 4.5, right? We plan to do and reach 4.5, and then we look at where we want to go from there. Thanks. Great.
Thank you.
Great.
So, Dr. Manoj, I think it will be okay if you have the time. I don't know if we can show the milestones of how the DTOs are performing, and how many milestones have they covered so far, and how much is still left to cover. Would you like to discuss it today, or we can do it later?
I think we can do it later. I think we want to spend a little more time, but we will say that the milestones are being tracked for all 534 DTOs, and they are in green, yellow, and then we will go that in more detail as we watch the DTO journey. If you wish, I will show you that this is the graphic that we will talk about in more detail, DTOs, your name and where you are at milestones and some of this. So Commodore Raman, more to come on this for our DTOs in the upcoming sessions.
All I want the DTOs to know is that your sessions and your interaction is not only ending with the counselor. All of us are looking at your data, at your progress. We are seeing where you need help, where you need more hand holding, and we are there for you. So this is only for that purpose, for you to get more encouragement and motivation that each one of us, all faculty and everyone is following you, and you are there, part of us as family.
Great.
Yes,
so our last 15 minutes, I want to go into topics which get a bit sensitive, and topics which are going to be now allow us to do the synthesis in a structured manner. Now comes thinking on a more structured way as well. But the sensitive part I want to say, data can also uncover fraud. I will share a story of one district. What they found, the data, was that DBT was excessive from a certain set of numbers in a certain part of town. DBT, excessive numbers. What was happening? They looked into it. The data drove them to look at that account. What the investigation found was that there was fraudulent fake numbers being developed, fake DBT data in order to get payment. Correct? So you as a DTO have that ability to use the data for oversight, not just to make decisions on what to do with your program, but to oversee the programs in a very structured way. And so we would encourage you that, yes, use your ability, your power, and your knowledge that others would not have seen to be able to see it. Because if others knew that you had that ability, they would not have done the fraud in the first place. What you have to realize, DTOs, is that you have that knowledge, that power, that ability to do that accounts verification, to uncover appropriate versus inappropriate. So now let us go into a couple of areas that we've talked about in data and how we look at it in terms of tracking. So first thing we've learned today is we can do a lot of graphs, but what we have focused largely on is what we call a run chart. What a run chart is a set of numbers over a period of time. Your x-axis is time, and we can do a graph over that to see what has changed. That is the most important for us in making very much decisions. And then there's simple things. You can see an upward trend or you can see a downward trend, correct? That's very simple, but it can get complicated. Well, what do we see here? Well, what we're seeing is that we have certain ups and then we have certain down as well. Dr. Mohan, any comments or thoughts from your end on some of these run charts?
Manoj, I would like to just tell you 2 or 3. We have to look out for 2 or 3 things, right? And the best place to learn and do this at this point of time is your laboratories, your DMCs. Your IRL shares you this data regularly because they do the RBRC. All the details will understand that. So, if you have a sequence of 7 or more, in a line going up or going down, it simply shows that you have to be alert. You are going to go beyond the 2 or 3 standard deviations either side, and you need to bring them back to normal. You need to look at that data, right? The other thing is, if you see the similar data copied throughout, 7, 8, 9, like Manoj showed, yes, like this, ideally it is a 7, but if you see something which is going in a straight line, it is a pointer. You have to be alert. Either the data has not been collected, somebody has just marked it, or somebody's coming for morning visit, just fill the data. So they don't, they just see what's there and fill it up. So these are pointers for you that you need to take a deeper dive into the data. Try to find the source of the data, original source of the data, and see where things are going wrong and get them back to normal. But you need to be able to read the data and understand the patterns.
Exactly. So this alerts you that there is something not right. If there's a monitoring group that's coming, they will know that this is cooked up information,
Manoj,
that it doesn't work.
Let me give you my experience, because I also go for evaluations and assessments in different states. This is the most common kind of thing we find, because for 2 months there was a festival and nobody had noted the data. You go there and you see a string of data, which is either at the same value or just above and just below, but you can easily note the pattern. So look for patterns in your data.
So let's talk about another pattern.
Wow.
So we've talked about various patterns. Now what we're seeing here is this alternative up and down, that there is variations that is going up and down. Now, this is no different from what we are seeing here. You see these jagged lines, and you see things even during recovery that something is going on. What this tells us is the following: that when you look at this data, that there is likely inconsistent reporting. अगर मैं आपसे ये पूछूं कि टीबी इस तरह से स्प्रेड होती है क्या? Is that you have 10 cases 1 month and 15 another, and then 0, 0, 0, and then again 15 and 20? It is not happening in that way.
Inconsistent reporting.
It is likely due to inconsistent reporting or entry. So that is what is likely happening, that during these months, there's reporting happening. These months, there is no reporting happening. And so it's not that there is no incidence of TB or there is no notification or finding of TB cases. It is just that the reporting has been there. Now, it can be a problem. Yes.
One thing to remember about TB is the incidence and prevalence will be usually smooth curve. Wherever it goes, whether it goes up or goes down, there is not a steep incline. The incline would be probably 1 degree, 2 degree, 3 degree, or 5 degrees, not more than that. But if you see something like this, you have to be alert about it and dig deeper.
Yeah. So your jagged lines are there. What it alerts you is that, wait a second, inconsistent reporting. Now you can say it's hard, my numbers are low also. I have numbers 5, 10, 3. How can I correct that numbers? Well, you can, rather looking at monthly, you can start looking at quarterly, correct? And you see that there's more smoothness than what was there before. But yes, the problem still exists that there have been some inconsistent reporting and entry, but quarterly makes it easier. It increases your numbers. What the point is that you as a DTO are going to be going through lots of graphs. Your ability to interpret those to be able to take action is incredibly important. मेरे काम में, मेरी लाइफ में करीब 20-30 graphs रोज देखता हूँ. Not for individual patients alone. Yes, patients का white count and fever के graph देखता हूँ, वो तो है. But city, state, county के country का COVID में trend किस तरह जा रही है and why. And then we look at these issues. Is it a reporting issue? Is this a issue of runs or cyclical issues? Is there an upward or downward trend? So there are clear guidelines on how to be able to do this. And this conversation has helped you understand and achieve many of those guidelines. Commodore Raman, was this helpful to you and to others who may not have a routine of looking at graphs in such detail every day?
Very, very helpful, Dr. Manoj. Only thing is, I am a kind of person quite contrary to, what you are. Moment you put a graph in front of me, I get scared. My mind shuts down. So if there are DTOs like me in this group, all I would like to share with you is just let it flow. The graphs will start talking to you. And I'm thankful to Dr. Manoj for introducing me to these graphs. Just keep documenting the data. The graph will start talking to you. That is the beauty of the graphs. And we don't have to get worried about them because the graphs get populated on their own. And you will see it yourself that when a Saturday, Sunday, or a weekend or a festival will come, and for some reason you will not be able to put the data, the graph will talk to you. Okay. Now, if there is no Saturday, Sunday, if there was no holiday, ASHA worker and TBHVs are telling you we are doing a lot of hard work. We're in the field, but the data is not showing. Then you will know for sure, and you will know for confirmed that something is not right, and it is time for you to take action. That is the beauty of data. Yes, Dr. Manoj.
So we've come a long way. A great conversation, discussions, DTOs. You have presented so much insight and so much knowledge, and each of you have shared. And collectively, we can do this. We can go to TB elimination, to TB free. Imagine if this knowledge permeated to every single DTO. Again and again, I say that because that is what success will be like. So, Commodore Raman, if you would like to say thank you to all our guests and others. Dr. Mohan, thank you so much also for your great insight. And so wonderful to have a detailed discussion. And we are open to this, more conversation. And also, if you feel that if something that we have said you don't agree with, we are more than open to your comments and questions and queries as well. So please don't think that we are fixed in our ways. We are more than flexible to be able to better understand and accommodate to your needs and to your questions.
Thank you, Dr. Manoj. There is still a minute, if you allow me, if I can utilize that. I had some closing remark to make to answer something. Okay, DTOs, a simple question to you. If the state government is not giving any sanctions, if the government of India is not filling your vacancies, can you still increase your team somehow? Is it possible for you to expand your team? The answer is yes. As of now, we have about 60 counselors who are working with you as part of your team. We are about 5 to 10 faculty who are day in and day out thinking about the progress in your districts and your problems. We have CTD joined us, we have WHO joined us, we have Emory University with us, we have Indian Institute of Public Health, Gandhinagar, and all the faculty, staff, and resources with you. So when you talk of your problems of HR or of anything else, please think that, we are expanding your team. There are other problems with other districts. Somebody has got problem of accessibility, of landslides, of floods right now as we are talking. Somebody's region, they have got manpower, but the region is tribal. The people, the general masses are not so educated. There are people, DTOs with problem that the acceptance to the policy and the scientific techniques is not there in the masses. All our problems are very diverse and different. There are certain districts which are states which are very, very well administered. There are certain which probably are lacking because of various historical causes, not for anybody's inefficiency. So there are many problems, but all we have to do is we just focus with what we have in our hands. And all my request and my closing remarks with you as of now, don't think too much. Plan your aim statement and your interventions. This is exactly what you've been doing all this while. All you have to do is just keep documenting the data. The PDSA sheet will speak to you. It will monitor for you. It will evaluate for you. It will delegate for you. It will supervise for you. It will reflect for you. And with this, thank you so much, videos. It is 6 o'clock. And as promised, we are ending the session. Please switch on your videos. Give a wonderful smile to us. We will now be videographing you and also marking your attendance. And thank you so much for the wonderful thanks messages which are coming in the chat box. Keep these thank you messages coming. This is all that we are looking forward to, your acknowledgement, your encouragement. And with this, thank you. Thank you, Dr. Manoj.
Thank you very much.
Special thanks to all the guest DTOs who have participated and made this memorable session.
Yes, thank you all. We will see you next week for another exciting conversation.